Today, a priority review designation in prostate cancer, a breakthrough therapy designation in bladder cancer, promising phase 3 findings in lung cancer, in addition to the NCCN Colorectal Cancer Guidelines, and a decision made by the CMS for genomic testing. Welcome to Enclave News Network. I'm Gina Columbus. The FDA has granted a priority review to a supplemental new drug application for enzalutamide for the treatment of men with non-metastatic castration-resistant prostate cancer. The sNDA is based on findings from the phase 3 PROSPER trial, in which the combination of enzalutamide and androgen deprivation therapy reduced the risk of metastases or death by 71% versus ADT alone for patients with non-metastatic CRPC. In the double-blind study, the median metastasis-free survival was 36.6 months with enzalutamide plus ADT, compared with 14.7 months with ADT alone. Additionally, there was a 93% reduction in the risk of PSA progression in the enzalutamide arm versus ADT alone. The median time to PSA progression in the enzalutamide group was 37.2 months versus 3.9 months for ADT alone. Under the Prescription Drug User Fee Act, the FDA is scheduled to make its decision by July 2018. The FDA initially approved enzalutamide as a treatment for men with metastatic CRPC after docetaxel therapy in 2012. This indication was expanded to include treatment in combination with the anti-androgen prior to chemotherapy in 2014. In urothelial carcinoma, the FDA has granted a breakthrough therapy designation to erdafitinib for the treatment of patients with metastatic disease. The designation is based on the global phase 2 BLC-200 study, in which the oral pan-FGFR tyrosine kinase inhibitor induced a 42% overall response rate in 59 patients with FGFR-positive, relapsed/refractory metastatic urothelial carcinoma. The study evaluated the ORR in patients with pretreated metastatic or unresectable FGFR alteration-positive disease who received one of 3 doses of erdafitinib. Across all doses, the ORR was 35% and the confirmed disease control rate was 76%. Moreover, the median progression-free survival across all dosing cohorts was 5.1 months. Investigators found that 75% of patients treated with 8 milligrams of continuous erdafitinib saw a reduction in the sum of target lesion diameters, regardless of the kind of gene alterations. The FDA's decision will expedite the review and development of erdafitinib. Phase 3 results of the IMpower 131 trial demonstrated that the addition of atezolizumab to frontline carboplatin and nab-paclitaxel delayed progression or death versus chemotherapy alone for patients with advanced squamous non-small cell lung cancer. Roche, the manufacturer of the PD-L1 inhibitor, reported that the full findings will be presented at an upcoming medical meeting. However, they did state that a statistically significant overall survival improvement was not observed at the interim analysis, and the study is now continuing according to its design. The co-primary endpoints for IMpower 131 were progression-free survival and OS. The study randomized 1,021 chemotherapy-naive patients with stage 4 squamous NSCLC to upfront treatment with atezolizumab, carboplatin, and paclitaxel, atezolizumab, carboplatin, and nab-paclitaxel, or the control arm of carboplatin and nab-paclitaxel. No new safety signals emerged with the atezolizumab regimen. Previous results of a phase 1b trial of atezolizumab with chemotherapy showed that 26 of 41 evaluable patients met the criteria for objective response, and 4 of 8 patients in the atezolizumab plus carboplatin paclitaxel cohort achieved objective responses. The combination of atezolizumab, carboplatin, and pemetrexed induced a response in 13 of 17 patients. Responses also occurred in 9 of 16 patients who received carboplatin and nab-paclitaxel in addition to atezolizumab. The NCCN has updated its colorectal cancer guidelines to recommend a weekly regorafenib dose escalation strategy beginning at 80 milligrams and ending at 160 milligrams for previously treated patients with metastatic CRC. This new dosing scheme calls for a starting dose of 80 milligrams daily on days 1 to 7, escalating to 120 milligrams daily on days 8 to 14, and concluding with 160 milligrams daily on days 15 to 21. For subsequent cycles, the NCCN recommends 160 milligrams of regorafenib on days 1 to 21 every 28 days. The updated results are based on findings from the Phase 2 regorafenib dose optimization redose study, which compared the dose escalation regimen with the standard dose of regorafenib daily. The median overall survival was 9.0 months in the dose escalation arm versus 5.9 months in the standard arm. The 6-month OS rate was 66.5% in the escalation arm versus 49.8% in the standard arm. 12-month OS also favored the dose escalation arm at 34.4% versus 26.7%. The Centers for Medicare and Medicaid Services has announced that it will cover diagnostic laboratory tests using next-generation sequencing for patients with advanced cancer. In a national coverage determination issued March 16th, CMS said it will approve coverage of genomic testing for patients with recurrent, metastatic, relapsed, refractory, or stages 3 or 4 cancer. The agency said such tests can help patients and physicians make more informed treatment decisions. CMS issued a proposed draft guidance for NGS testing in November when the Foundation 1 CDx test won simultaneous FDA approval and CMS coverage. Overall, the decision means that CMS will cover FDA-approved or cleared in vitro NGS diagnostics when the test has a companion FDA-approved or cleared treatment option, and results are provided to the treating physician for management of the patient using a report template to specify treatment options. Medicare administrative contractors may determine local coverage of other NGS tests as a diagnostic laboratory test for patients with cancer, such as MSK Impact. The decision also provides coverage for repeat testing when a Medicare patient has a new primary diagnosis of cancer. This week, we sat down with Dr. Jonathan Rosenberg of Memorial Sloan Kettering Cancer Center to discuss the promise of DNA vaccines in bladder cancer.
One approach that we're using is using vaccine therapies to target cancer. In bladder cancer, one approach that's being tested is a combination of multiple different antigens in a vaccine preparation called INO5401. This is an injectable DNA vaccine targeting WT1, HTERT, and PSMA, all of which are tumor antigens that are overexpressed in bladder cancer. It's also combined with an immune stimulatory molecule, IL-12, to allow for the immune system to recognize these antigens and hopefully attack the cancer. And it's being combined with immune checkpoint blockade. In other studies, it's been shown that these DNA vaccines are generally quite safe without a lot of toxicity and therefore have a lot of promise to be combined with immune checkpoint blockade, particularly in bladder cancer where patients often have multiple comorbidities that prevent them from being treated with highly toxic therapies. So this vaccine is delivered via electroporation where there's actually a proprietary system that's used, which is almost like a gun that's applied to the patient's skin that injects the vaccine directly into cells with an electric current, causing the DNA to be taken up into cells and presented to the immune system, along with the immune stimulatory molecule, which then acts in the tumor microenvironment to recruit immune cells. This educates the immune system, hopefully sending these cells out to other places in the body to find these antigens and attack cancer cells. This sort of approach has shown early evidence of efficacy in cervical cancers and cervical intraepithelial neoplasia, which is a virally mediated disease using different targets. But the concept is that the immune system will recognize these and actually attack these precancerous or non-invasive malignant lesions in cervical cancer, and that's being tested in a randomized phase 3 trial right now. In bladder cancer, this vaccine is going to be combined with atezolizumab, one of the PD-L1 targeted immune checkpoint drugs, and we hope to see some data on this combination in coming years. The idea would be that the immune system is now poised to respond to the cancer, and the addition of a vaccine therapy would increase the likelihood of tumor regression in these patients. And it's really being tested first in patients who have progressed following immunotherapy with a checkpoint inhibitor. And the idea that if we see immune responses and clinical responses, that in fact it really is related to the vaccine rather than the continued use of an immune checkpoint agent. This trial is targeted towards patients who have metastatic urothelial cancer, previously progressed on an immune checkpoint agent. These patients have to be fit enough to go on a clinical trial, but if they have progressive cancer on an immune checkpoint drug, the likelihood of them having an additional response to continued immune checkpoint therapy is very low. The hope is that with the addition of the DNA vaccine, that this will induce an immune response that would be durable, and patients would derive substantial benefit from that. And then it would move forward in testing to earlier stage of bladder cancer in larger clinical trials.
That's all for today. Thank you for watching Enclave News Network. I'm Gina Columbus.